Good. I'm Dr. Paul Hain. I'm the Chief Medical Officer here at Blue Cross and Blue Shield of Texas. Welcome to what healthcare affordability means post-COVID-19. We have a very impressive group of panelists today. Niall Brennan is the President and CEO of the Healthcare Cost Institute. Lauren Adler is the Associate Director of the USC Brookings Schaefer Initiative for Health Policy at the Brookings Institute. And Avik Roy is President of the Foundation for Research on Equal Opportunity. All three will be sharing some content with us today, some opinions about what healthcare looks like and what affordability means after COVID-19. But we're going to get started with Niall. So let me tell you just a tiny bit about Niall so that you know that he's bringing a lot to the table here. As I said, he is the President and CEO of the Healthcare Cost Institute. He oversees their entire research agenda. He really works to maximize the reach of HCCI, Healthcare Cost Institute, HCCI's data by licensing directly to academic researchers and through the role as a Medicare certified qualified entity. He works closely with federal and state policymakers, including the US Congress, believe it or not, on key health policy issues. And he is nationally recognized. He can't go through an airport without people yelling, "Hey, Niall, over here." He's nationally recognized in healthcare policy, the use of healthcare data to enable and accelerate healthcare system change. And he publishes in the big boys, right? He's in JAMA, he's in the New England Journal, he's in Health Affairs. So Niall, I can't wait to hear what you have to say. Go ahead and tell us what you think.
Thanks very much, Paul, for a fantastic introduction. And thank you, everybody, for joining the panel. I have very fond memories of speaking in person at this conference last year, and really hope that we all get to a stage where we can all meet in person again soon. I don't know about the other panelists or the attendees, but I'm getting quite sick of Zoom and virtual life, although it's the best thing for us right now. So let me get started. Again, it's great to be here. And I think, you know, what healthcare affordability means post-COVID is a little bit of an unknown. And I think we have to understand what, you know, healthcare affordability kind of meant pre-COVID. And certainly, we have struggled for a very long time in this country with an unsustainable trajectory in our healthcare spending, particularly our healthcare spending in the commercial population. You know, you can argue that Medicare perhaps has been slightly more successful in keeping cost growth to low or historically lower trends over the past few years. You can also argue that Medicare has more tools to make that happen because, you know, they're a price setter and not a price taker. So just really quickly, little maybe advertisement for those of you who don't know HCCI. We were originally founded with data from United, Aetna, Humana, and Kaiser. United Health Group pulled their data from HCCI about a year ago. And so we're really happy to announce that we will be relaunching our new data asset just in a couple of months. My team has the data now and is QCing it and checking it. And so we will be launching this very shortly. It will have over 55 million lives for people with commercial coverage. And then, as Paul mentioned, we're a Medicare qualified entity, so we have an additional 40 million lives a year. So it really gives us a unique opportunity to take a deep dive into what's going on with healthcare spending in the commercial sector, and then, as Paul also mentioned, to license it to researchers. So many of you have probably seen this slide in previous presentations that I've given, but I think it lays out in very stark terms the problem we have with healthcare spending growth in the commercial sector. The 5-year trend from 2014 to 2018 was 18% growth, ranging from a low of 11% in the hospital sector to a high of over 25% for prescription drugs. The prescription drug estimate does not include the effects of rebates, which I know is important to include, but that data can be quite hard to come by in a large scale database such as ours. And so what's driving the spending? It's essentially price. So we tried to take the entire $610 per capita growth over this time period and decompose it into how much of the growth was due to unit price increases, how much of the growth was due to utilization, and I'm sure Lauren and Ovik are going to talk about some of these issues too, and how much of the growth was due to changes in age and gender composition. So you can see by far the greatest contribution to growth over this time period was price, $453 out of the $610 total. So taking a look at Texas, this is using our Healthy Marketplace Index tool, and you can see that the trends in Texas, again, are broadly similar to that of the nation. You have spending growth of 12% in Dallas from 2013 to 2017, 15% in Houston, 15% in Austin, Texas, and 23% in San Antonio, Texas. And right below those trend lines, you can also see the relative impact of price, use, and service mix on the overall trend. And then at the very bottom, you can see that this is all happening against a backdrop of more and more consolidation and less competition in the hospital sector. And so I think, I joke that economists really love to disagree with each other and really the world a lot of the time. But there's near unanimity among economists who study the issues of hospital consolidation that it is bad for competition and almost invariably leads to higher prices in healthcare. You'll notice in the very bottom right-hand corner of the slide that hospital market concentration actually decreased a little bit in San Antonio, but it's decreasing from a very high base. San Antonio is a highly concentrated hospital market area. And so taking a look at it again from a macro level, we analyzed 124 different CBSAs nationally over this time period. And so you can see that the prevailing trend is towards less competition and more consolidation. In Houston, Texas, the market became significantly more consolidated. And again, you can see at the bottom of the slide that even though San Antonio, its Herfindahl index decreased from 3.6 to 3.2, that number in and of itself represents a highly concentrated market.
And Niall, if I can just ask you one question while you're going, just to clarify for the folks at home, when you say price or cost, what you mean is actual money changing hands, right? Not some kind of mystical charge master somewhere.
That's absolutely correct. All our analyses are done using the allowed amount, the negotiated rate, whatever you want to call it. So this is not the Saudi Arabian prince price. This is the price that American workers and their employers pay every day of the year. So I know we're going to get into a discussion of what some solutions might be to these problems as we look forward into 2021 and beyond. And I think it's very highly instructive to also look at commercial prices as they relate to Medicare prices. So I'm going to show you some comparisons of Medicare prices to professional services, essentially physician services, but that HCCI did. Before we did this, we did a lit review, and Kaiser has done some great work in this area. So you can see that prior studies have found that inpatient commercial prices tend to range roughly about 2 times the Medicare rate. Some are below 200, some are above 200, but it's in and around 200. There's a a lot more variation in prior studies have found a lot more variation in outpatient rates relative to Medicare, but some studies have found that outpatient rates can be as much as almost 4 times greater than Medicare. And then you can see for professional services, the HCCI research that I'll present to you shortly kind of falls pretty much in the center of previous studies comparing Medicare rates to commercial rates for physician and other professional services. And so again, here's a state look at average commercial service prices relative to Medicare for professional services in 2017. And you can see that Texas actually does reasonably well. There's a lot of clustering around 120% of Medicare, although there are states as high as almost 2 times the Medicare rate. Wisconsin is a very clear outlier there. Interestingly, there's even a state where the commercial rate is a little bit less than the average Medicare rate. In Alabama, commercial rates are average only 98% of Medicare rates. And so why is this important? Well, one of the reasons I think why it's really important is when we look at this, again, market level decomposition of healthcare prices in Texas relative to Medicare. And you can see that in Texas, there are several areas, Corpus Christi and McAllen, where commercial prices are actually less than Medicare prices. But at the other end of the spectrum, in Lufkin, Texas, I hope I pronounced that right, commercial rates are 152% of Medicare prices. So, you know, we are obviously in a very uniquely interesting week in American history, but, you know, there's been a lot of conversation about public options and all payer rate settings and benchmarking to Medicare rates and different things like that. So you can see, even if you did go down those roads, you would have to think very carefully about what the market level impacts of those things would be, because the wrong policy could lead to some very unintended effects. If you do a broad brush policy pegging all commercial rates to a certain percent of Medicare in Texas, you can see would have dramatically different ramifications for different areas. It could be a windfall for some areas and provide significant financial dislocation for others. So those are the conclusion of my slides. I'm really honored to be on with Lauren and Novik, and look forward to hearing what they have to say. So I think I'm going to hand it over, stop the share, and hand it over to Lauren.
Outstanding. Thank you so much, Niall. Let me introduce Lauren real quick. And for those folks at home, let me just give you a quick house cleaning details here. There is a chat function in here that you can ask questions while we're going. There was one question asked while Niall was going, but he actually answered it. So we won't be diving into it. But please, we'd like to interact as much as possible. I'd also like to point out to the folks at home that Niall was not honored to be on the panel with me, just Lauren and Avik. So as long as we all keep that in mind, I think we'll do well. So let me tell you a little about Lauren Adler. Let me tell you about Lauren Adler. I already told you that he has some big, really cool titles at the incredibly well-respected Brookings Institute. He's an associate director there at the Initiative for Health. His research focuses on a range of topics in the healthcare milieu, including economics and policy, provider payment and consolidation, insurance markets, the Affordable Care Act, prescription drugs, access to coverage, and something near and dear to our hearts in Texas, because I believe we're the leader of this in the nation, surprise billing. Lauren frequently provides technical assistance to federal and state policymakers and frequently contributes timely analysis of healthcare policy and regulations, meaning he's a big deal in Congress and he helps a lot of people figure out how to think about this stuff. So it's good to pay attention to him. Lauren, we're going to turn this over to you for a while.
Okay. Thanks for having me here. Let me get this up. Yes, well, I'm honored to be on the panel with you as well, Paul, and Niall and Ovik here. So thanks for having me. I kind of wanted to jump off a little bit where, jump off a little bit where Niall got us started there. So, right, he kind of, the HCCI, the awesome data there sort of breaks down, how much of healthcare spending growth is really attributable to utilization versus unit prices and the age mix. But Right. So generally, when we're talking about prices, we're talking about either utilization or unit prices. I don't think we should completely write off utilization. We've had some mild improvements with things like accountable care organizations and bundled payments, but it certainly seems that there is a growing body of evidence that our main sort of outlier spending in the United States really mostly stems from high unit prices that are paying for largely hospital care, but also prescription drugs and physician care as well. I always like to take a step back when I have these discussions because I think sometimes it gets lost of just sort of the fundamental question of what should prices be, and really you want prices to be high enough to cover an efficient provider's cost of delivering appropriate quality care. So this is a very hard thing to drill down because what prices incent want quality is not a very simple empirical question. But that is that is what we're hoping to accomplish here. And right, there's many consequences of excessive prices. Some of these are very obvious of just the financial burden that can place and just sort of inefficient care delivery as well. But right, there also are consequences if prices were set too low, right? That you could have access to care issues or you could have lower quality of care that results from sort of paying too little for healthcare. Always like to sort of start with that before kind of getting into the sort of bigger question of why are prices so high in private insurance, right? We're really kind of focused on the commercial insurance market here rather than, the public programs like Medicare and Medicaid. And really when we sort of think about how do we know that prices are high here, certainly we have some of the international comparisons. We also have a lot of the work that HCCI and others have done showing just how a ridiculously wide the variation in prices that are paid by commercial insurers across even the same region, the same locality, but particularly across localities. And then also the fact that we have had a growing divergence over the last 10 years between what Medicare pays and what commercial insurers are paying, particularly for hospital care. Those are kind of our main points of evidence that prices may be inefficiently high. And right, I think there's many plausible reasons here. Certainly limited competition has some effect here, right? With the HHIs in hospital markets are high and growing over this last decade. I don't think there's really any argument about that. And neither is there really any argument that those are price increasing without really having much effect on quality really at all. So there is certainly an incentive to doing something about that. But I think the empirical literature is also clear that limited competition is not does not explain the full explain fully why prices here are so high. There are plenty of other reasons. So some may simply be that consumers place a very high value on choice of provider. That may be, when we say consumer here, we may actually be talking about an employer who just has a very heterogeneous workforce, and therefore there is sort of effectively a kind of higher value being placed on having very wide range of choice. And certainly if you look to large employer plan networks, it is often that basically every hospital in a region is in network. So certainly that blunts any sort of even if there is some competition between hospitals, if you kind of effectively have to have all 4 hospitals in network, insurers don't really have that much of a lever to drive down prices. And then sort of related, but certainly there are some public policies that limit insurer leverage here or sort of blunt incentives for cost control, whether that largely here when you're talking about the employer market, the fact that we have a blanket subsidy, a tax subsidy that all the employer benefits, health benefits are tax-free, that certainly just limits some of the incentives for cost control. This last one is sort of no proof here, but the fact that there's greater public sympathy, I think probably fair to say, for providers than insurers in the general public may have some harms, because certainly you've seen plenty of times that there is a hospital versus insurer or staffing company versus insurer fight that plays out in the media. So it's certainly plausible that sort of sympathies can play some role in that. And then turning to, I kind of wanted to focus most of my remarks on thinking through, the solutions that you might want here without necessarily giving sort of a clean prescription. I think the first sort of bucket of things here are, let's try to make markets work better. and honestly, even if you sort of tiptoe into the next group of policies that are going to be more on the sort of administrative price setting aspects, many of these can still have value. So some of that is just, being better about antitrust enforcement, whether that is, much greater funding for the FTC, is that sort of changing the presumption of harm when you have mergers. There's just a lot of mergers, and especially when you get down to the physician level, which is a lot of my research right now is sort of focused on physician consolidation. And at that level, it's just hard. Even the larger physician mergers are kind of hard to really tackle from the federal level. And then jumping back to the tax exclusion for employer provided coverage, that certainly plays a role here as well. And then sort of the bevy of state rules like anti-willing provider requirements, your certificate of need policies, and all of that certainly play a role in hampering competition. I think there are ways to do that. There's also the aspect of trying to make price shopping easier. I think evidence is pretty limited, to say the least, that there's much effect you can really hope for in terms of price transparency aspects, but I'm not sold that it's zero. I think particularly when you talk about transparency to employers, as thinking of them as the consumers here, I think there is a possibility that some of the recent transparency, efforts of the Trump administration may have some fruit. I don't think you're talking about wholesale changes, but taking a few percentage points off prices, which I think is in the realm of possibility, is something that is still worthwhile to talk about. Sort of turning to the other grouping of products here, this is where kind of I think folks certainly in recent years has gotten a lot of attention for different administered pricing type approaches. And some of that is, obviously the most direct thing is you could do Maryland style. We're just going to literally say what all of the prices are. We, the government, or we're going to set all the prices. We're going to somehow figure out how to price every single good in the healthcare system. And that's not, we have Medicare basically does that. So you could have something like that is a much broader way to do that. I think a lot of people more recently have talked about things like out-of-network caps, where you just sort of say a provider isn't allowed to charge more than X, and sort of an insurer is not allowed to pay more than X for out-of-network care. A sort of big problem there really is unless there is a requirement to actually treat the out-of-network patients on that is sort of placed on the hospital, it's not clear that really has that much effect at the end of the day, particularly once you're outside of the sort of surprise billing world where where there is less, an emergency doctor can't turn away a patient, but a large hospital can just say, I'm not going to treat the patient if you don't pay me enough money, even if there's an out-of-network cap in place. I don't really talk about it here, but I think it kind of jumps off of a key point Niall made in just when you're looking at the very wide range in prices paid by commercial insurers across the country and within states. A lot of these sort of rate regulation policies run into difficulties of, do they actually increase prices in some areas, or at least sort of have no binding effect in certain areas? Certainly, I think that gets you to thinking about certain policies where, for instance, you could sort of create something like a default contract where there is something where, hospitals, there is a required by law, hospitals have to accept, a fee-for-service contract at 150% of Medicare, sort of across the board for all their inpatient services. And if the insurer wants to take that is on the table by law. That sort of changes the leverage scenario here, so that they can't. The hospital now then that sort of, I guess is another way to think it. It sort of you can chop off the right tail to some degree, right? Now you can't really charge prices more than that. The insurer always says the fallback, but you're not prescribing exactly how to pay for care, which I think is where you run into a fair amount of difficulties if if we want to start outlawing per diem contracts or ACO contracts or something like that. This sort of gives you the option to sort of put a foot on the scale a little bit without sort of forcing people to tell people how to pay for care. The last ones is right. You can also increase reliance on public insurance programs. Public options get a lot of say here, and they have some of the similar attractions in that, right? You pay fee-for-service prices in this public option, and that the competition with the public option effectively, similarly, right? You're not telling private commercial insurers how to contract and how to pay for care, but they can now go to the providers and say, look, I'm not going to pay you more than this because no one's going to buy my plan because the public option's, paying 125% of Medicare. So you better give me a deal along those lines. And that's basically what we see in Medicare Advantage today, right? There's plenty of private insurers in Medicare Advantage doing well, but they are, they're paying provider prices similar to Medicare's. Sort of just jumping on this to end things off. I also kind of wanted to at least quickly touch on, right, I focused here on, I think, some of the sort of bigger picture provider pricing issues. I think there's also a handful of sort of smaller things around the margins that are useful to try to get at, whether that is surprise billing, which has obviously gotten a lot of attention in Texas, right? That is right. We're talking about a pretty clear market failure that affects spending on, pretty much emergency care and anesthesiology and a handful of other things. I think that is very important. I focus a lot of my time focused on it, but in some ways, addressing some of these broader problems would also any of these sort of administered price things would get rid of surprise billing sort of in one foul swoop as well. So I think there are plenty of things along those lines. I think the transparency efforts sort of fall in that little side bucket as well, that there are things you can probably do on the margins short of sort of these wholesale changes that I'm talking about. And on that, I'll turn it over to Ovik, or Paul, to introduce Ovik.
Thanks, Lauren. Hey, fantastic. Again, a reminder, if you have questions about the presentations as they're going on, go ahead and throw them into the chat box. But we will continue over with Avik Roy, who is the president of the Foundation for Research on Equal Opportunity, which is a nonpartisan nonprofit think tank that conducts original research on expanding opportunity to those who least have it, a very important area. And among other titles, Roy is the author of Medicare Advantage for All, a patient-centered plan for universal coverage and permanent fiscal solvency, published in 2019. He serves on the advisory board of the National Institutes for Healthcare Management, is senior advisor to the Bipartisan Policy Center, and co-chaired the Fixing Veterans Healthcare Policy Task Force. Roy also serves as the policy editor at Forbes and manages The Apothecary, the influential Forbes blog on healthcare policy and entitlement reform. So to kick off the end of the trifecta of really impressive policy folks we have here today, Avik, take it away.
Well, thanks for that introduction. And I will say, as an Austinite and the CEO of an organization that is headquartered in Austin, I welcome your efforts to make my health plan less expensive than it is, because our premiums have gone up 15% every year that I've been running free out. So I'm going to do my best to give you some hopefully useful information to do that. And the thing I'm going to focus on today, look, what we heard from my colleagues on the provider side, we've written a lot about the provider stuff too, but I figured since they're so good at that, I'll leave that to them and I'll focus on drugs, which is another area, obviously, as you all know, of increased premiums and increased health spending overall. But particularly for the non-elderly population, prescription drugs is actually, according to AHIP's analysis, I think the single largest line item actually is prescription drugs. They're at about 24% of the private insurance premium of claims. And within that prescription drug bucket, the biggest driver, as I'm going to explain in my slides here, is biotech drugs. Not specialty drugs as you're used to thinking about it, but biotech drugs specifically. And what do I mean by that? So one thing you'll hear from the pharmaceutical industry and people who support the pharmaceutical industry is that, look, actually, we don't have a drug pricing problem, because the vast majority of prescriptions in the US are for generic drugs, which are dirt cheap. It's actually true. Like for me to get a 30-day supply of atorvastatin, which used to be called Lipitor, it doesn't cost that much. The copay for me is somewhere between $0 and $10. And that's a pretty important drug in terms of my health outcomes, right? So 79% of all prescriptions in the US are for unbranded generic drugs, which is by far the highest, by healthy margin, the highest in the world, and well above what you see in Europe. And this goes to the point that in a sense that we were making, that others were making too, like Niall and Laura, that it's the price piece of this is really important. Utilization, when it comes to utilization of commodity price generic drugs, we're actually the best country in the world. But we're still spending more than double on prescription drugs than any other country. Why is that? Well, the reason is the growing spending net of rebates on biologic drugs. Biologic drugs meaning drugs that are manufactured in living cells, right? So monoclonal antibodies, vaccines, other protein-based therapeutics. Those are the drugs where we're seeing the net growth in spending. We're at a point now, as of 2019, where spending on biologic drugs is almost equal to, net of rebates, what do we spend on small molecules. And you'll notice those orange bars in this chart are actually going down, and I'll make that more explicit here. In the last 4 years, net spending on net of rebates on small molecules has actually declined, even before you adjust for inflation. It's declined at an absolute nominal level. So we hear all this talk about healthcare and inflation. It's like a law of physics. The price of everything goes up every year, and there's nothing we can do about it. Well, don't tell that to the smart insurers out there. They're doing a great job with the PBMs of negotiating good deals on small molecules, because we're seeing small molecule spending going down every year. You know, where the spending is skyrocketing.
For those folks who never took biochemistry in college, do we want to explain what a small molecule drug is?
Yes, apologize if I didn't make that clear. So a small molecule drug, in contrast to a biologic drug, which is manufactured in living organisms, these large protein molecules like a monoclonal antibody. A small molecule drug can be synthesized in a high school chemistry lab, like Lipitor, like your conventional antihypertensive drugs. These are drugs that typically have about, let's call it 10 to 20 to 30 atoms, or in other words, their molecular weight is relatively small. And that's why they typically can be administered in pills. They're pretty easy to formulate. Biologic drugs, because they are made of more complex proteins, often have a molecular weight, instead of being 100 Daltons or 50 Daltons, their molecular weight might be 50,000 Daltons, or 100,000 Daltons, or 200,000 Daltons. Because these large proteins are much larger molecules involving a lot more atoms, their structures are much more complex and can change if you put them in different preparations. So, for example, if the pH if the acidity of a solution that contains that protein is different, the protein's shape may be different, and its therapeutic effectiveness may be different, and its side effects may be different. So for all these different reasons, the way you, without getting too into the weeds of biochemistry, biologics are kind of a different beast in a certain way than small molecules, certainly in terms of the way they're manufactured and synthesized. And most consequentially for our purposes, the way in which biologic drugs are regulated by the FDA and by Congress is totally different than for small molecules. You're all familiar with what happens with small molecules. The drug, after a certain period of time, goes off patent. And when it goes off patent, the generics come in, like in the case of Lipitor or Crestor, the generic atorvastatin or rosuvastatin comes in, and all of a sudden, this drug that was really expensive, that was a $10, $20 billion drug, becomes a commodity drug in which you can get it for almost nothing, right? And that's been the success story of American pharmaceuticals. And what I'm trying to drive home to you is that's not happening for biologic drugs like Humira, the AbbVie drug, which is now the world's best-selling drug, where instead, what you're seeing is that drug continues to be a branded drug and will be a branded drug for a considerably longer period of time than we normally expect for small molecules. Here's a way to drive this home. Biologic drugs are the orange part of these donut charts. Biologic drugs, the drugs that I'm talking about that are synthesized from living organisms that are monoclonal antibodies, other large proteins, represent 0.4% of US prescription volume and 46% of US pharmaceutical spending net of rebates to PBMs and wholesalers. 46%, right? So when you talk about the rise in prescription drug pricing, we have these somewhat arbitrary distinctions that you're used to hearing about, like specialty drugs versus non-specialty drugs. Forget about that. Focus instead on something that's actually a much more objective description of the problem, which is this drug regulated or governed by Hatch-Waxman, the law that really governs the small molecule drugs, or is it regulated by the Biologics Price Competition Innovation Act of 2009, which is Title VII of Obamacare, which is what governs biologic drugs? If it's governed by the latter, it's part of that 0.4%. If it's part of the former, if it's part of Hatch-Waxman, it's the 99.6%. And that legislative architecture is driving everything, because it's because biologic drugs are governed by a completely different part of federal law. And that's the reason why competition for biologic drugs is so much stickier and so much more heavily restricted, and the barriers to entry are so much more considerable for biologic drugs than they are for small molecules. Here's an example of what I'm talking about. If we simply had the regulatory system of Europe, which is not a libertarian, unregulated system, right? They have regulations too. But in Europe today, as of 2019, there are 61 approved biosimilar or generic biologic drugs compared to 28 in the US. And that gap, for the longest time, we only had one approved biosimilar in the US, where, like take 2014, there was one approved biosimilar in the US and 21 in Europe. Now it's 61 and 28. So while the FDA is finally getting its act together, we're still far behind Europe. And we've estimated at FREOP, as I'll get into later, that the cost of simply the difference between US and European policy regarding biosimilar adoption is costing American patients $30 billion over a 15-year period from 2015 to 2030. So here's the market share of biosimilars on a dollar basis in the US. The orange bar is biosimilars and the blue is biologics. And that's despite the fact that we've had biologic prescription drugs like Epogen, the Amgen drug that Lance Armstrong and others used to cheat in the Tour de France. That drug has been around since the 90s. It's off patent now, but we're still not seeing those biologics. Why? Because Amgen, the manufacturer of Epogen, basically did this kind of patent trolling where they filed all sorts of incremental patents that the US Patent and Trademark Office granted them that they used to block a competition that were not granted in Europe, because in Europe there's a much smarter system for incremental patent trolling type approaches to preserving your monopoly. And this is what I was talking about. If we're just looking at 8 drugs, the 8 largest biologic drugs in the US, things like Avastin, Neulasta, Lantus, Herceptin, and again, Remicade, Enbrel, Rituxan, and Humira, $30 billion. And that's a conservative estimate because that's only basically 8 drugs, right? There are a lot of other biologic drugs that are out there, particularly for ultra rare diseases that I'm not even talking about here. So that's the end of my my kind of this going over some statistics here. And I guess what I'd say is, okay, so what should we do about that? What can we do about it? What can you do about it as plans in Texas? The thing that you can do is know that so-called biosimilar drugs, and by the way, the term biosimilar is itself a kind of art of lobbying, because the goal of manufacturers of biologic drugs was to argue that you can't put people on biosimilars because they would be unsafe compared to generic drugs. That's why you had to have a completely different regulatory structure. And to scare patients and doctors and not prescribing those biosimilars. But what you can do as plans is have the confidence that any quote unquote biosimilar that's been approved by the FDA is just as safe and effective as the reference biologic branded drug. And you guys can do a lot more to persuade doctors, to educate doctors about the safety and effectiveness of those biosimilars, and encourage more widespread adoption, to encourage pharmacies to substitute those drugs where the law allows, but particularly to really educate physicians, prescribers, as to the utility of these low-cost biosimilars as they come on market. Because if you do that, you're going to have more ability to engage in the kind of price competition among those drugs that has proven so successful with small molecule traditional drugs. With that, let me stop.
Thanks, Avik. That's really interesting. I have been kicked out of my panelist mode, so I can't see the chat box. If there are questions coming in, I'd love it if one of our panelists would take a look at them and let me know. I, however, do have a couple of questions. in lieu of anyone with something in the Q&A box. Avi, you were talking about the difference between biologics and small molecule drugs, and you were very clear on that, so thank you. First, let me ask you, is there some kind of rationale in treating them differently? Are biosimilars inherently more difficult to prove their efficacy than small molecule drugs? And as a follow-up to that, if we do have biosimilars on the market, do they seem to be altering the price? Are they coming in as low as the small molecule generics?
Great question. And for more information on this general topic, if you really want to, if people on the call want to do some deep dive into this, we have a paper that has the same title as my slide deck. Biotech monopolies are a threat to affordable care. That I will make sure that you all have the link to, and then the THP can send out, that goes through a lot of this history. So the answer to your question, Paul, is that there was a single incident with a biosimilar drug in the 2000s that basically what we might say is the branded lobby was able to use to scare people. What happened was, so you're familiar with Epogen. In Europe, the license to Epogen is owned by Johnson & Johnson. And Johnson & Johnson's Eprex in Europe, the European Medicines Agency, which is their equivalent of the FDA, required that at some point there was a kind of a scare around albumin for some reason. I don't remember exactly why, but people just decided that they wanted to get rid of albumin because they thought it was bad. And so the EMEA asked Johnson & Johnson to come up with a way of manufacturing Eprex that didn't involve albumin. So they did that, and it turned out that this new version of Eprex, their replacement for human erythropoietin, which is the hormone that helps your basically tells your kidney to manufacture more red blood cells. What was happening to a percentage of patients who got this new version of Eprex is that their bodies were developing and they were recognizing this drug as foreign, and their bodies were developing antibodies to this foreign erythropoietin that was cross-reactive to their own native endogenous erythropoietin, and that basically wiped out their own kidney, the patient's kidney's own ability to manufacture erythropoietin and thereby to stimulate red blood cell formation, which led to this ultra-rare disease called pure red cell aplasia, where basically these people couldn't make their own red blood cells. So the biotech lobby basically looked at that and said, see, this shows that biologic drugs are dangerous, and if you don't do, if you basically treat it like generic drugs, then you know, people could die, or people could have these rare diseases like a pure red cell aplasia. When in fact what happened was the EMEA imposed an arbitrary change to the manufacturing process, which they didn't validate, that led to all these problems. So all that to say that if you actually do what we should have done all along, which is say, okay, the branded reference drug has this manufacturing process, it's synthesized in this cell line, and you do it this way, A, B, C, D, E, and you instruct the generic or biosimilar manufacturers to do the same thing, it should work fine. In fact, the FDA already regulates this process. So when, you know, let's say Genzyme, a biotech company, wants to manufacture a new version of their drug in a new plant, the FDA goes in and inspects to make sure that the new plant's process is exactly the same as the original plant's process, right? We could do that for biosimilars very easily. So all this to say that there's this one historical example that a lot of people have cited to scare people, but the end result, the actual real world experience of every other biosimilar, and that wasn't even a biosimilar, that was a branded drug, of every biosimilar, is that they're safe and effective and work just fine. To your other question, Paul, about the price action, whether we're seeing the prices be like commodity prices like biosimilars, we're not seeing the same level of drops with small molecule drugs like a Crestor or a Lipitor or a Norvasc. The price drop is 80% in the first year of the generics coming online. We're not seeing 80% price drops. We're seeing price drops more like 30% in the first year, and then 50 to 60% year 2 and 3. Partly that's because fewer people are competing because of all the regulatory barriers, so there aren't as many manufacturers competing against each other. And the second part of it is because of FDA regulations and also congressional statute, it costs more to manufacture and develop biosimilar drugs, which means that for those biosimilar manufacturers to recoup their upfront costs, they have to charge more. So there are price discounts. They're not as aggressive as the small molecules, but they're still significant enough that if you're a carrier that is seeing a lot of claims costs from Remicade and Humira and Enbrel, you should be able to save a lot of money.
Thanks, Alex. That was very clear. Hey, Lauren, I want to pivot to you on this and ask you a little bit about something that's the same genre, but more up your alley, about getting people to think about shopping for these drugs, right? Avik was talking about how they actually aren't that big a decrement, but if you could get people to turn to them, that'd be really helpful. How do you do that in an arena where these drugs can cost $20,000 a year? And we know that by law, out-of-pocket maxes are set around $7,000. So if you move from a $20,000 drug to a $10,000 drug, you've saved yourself exactly nothing. How do you get people to shop?
I mean, I think you raise a very important question that kind of goes beyond just prescription drug pricing to really any particularly expensive healthcare service, right? Plenty of inpatient services would have similar difficulties here. On the small scale, sure, there's often cost sharing, at least earlier in the year, and that can have that can have some impact to the extent that folks are paying, and insurers can still sort of drive to some degree. So to the extent that there is a biosimilar on the market, then there can be pretty differential cost sharing. That is right. You're hitting your out-of-pocket max based on your own cost sharing. So if it's worth it from the insurer or the employer's perspective to get folks to shift to biosimilars, right, you can charge them near nothing if they use the biosimilar, and obviously lots and more money if they're using the branded biologic. So certainly there's elements like that. And at the end of the day, there's also, right, I think people often in the price transparency thing sort of gets stuck sort of laser focused on just the patient themselves doing these shopping decisions. But even if there are sort of strong cost differentials, patients are, especially when you're kind of into very intensive care, are so deferential to their providers, understandably, because we don't have the medical training to make a lot of these decisions. So at the end of the day, a lot of this is, one, as Ovik was talking about the actual prescribers, and talking about their prescribing habits, but also just right, the employer, at the employer level, you can still be having these negotiations as long as there are somewhat of options on the market, whether that is two drugs in competition or a prescription drug and a medical service on the competition that are in competition. But fundamentally, then it is just sort of using cost sharing, differential cost sharing as a tool. And once the insurer is able to drive volume to the sort of preferred product, at that point, that gives that really gives the leverage to then go back to the drug company and give power of negotiation.
Thanks, Lauren. That's very clear. Niall, let me shift over to you for a sec. Staying on the aspect of these really expensive biologics, how's Medicare handling that? You've done a lot of research on what things cost in relation to Medicare pricing. Is Medicare doing a better job at this than commercial?
I'll be totally honest. I'm not sure. Ovik's probably better qualified to speak to it than me. I mean, I do know that there are some some of the structural, the way the Medicare Part D benefit is structured. So much of the benefit ends up being covered by reinsurance that a lot of people feel that there are not real incentives for PDPs to rein in costs. But Ovik, do you want to weigh in here before I embarrass myself too much?
No, I mean, I would agree with what you said. I would just add to it that compared to the provider side, where Medicare does have a structural advantage relative to the private plans, on the prescription drug side, it's the plans that actually have been really driving a smarter approach, in the sense that, think about Medicare Part B, as in boy. where you have this dumb system where you turn doctors into real estate brokers, where they get a 6 or 4% commission based on the drug they give you. So obviously they're incentivized to prescribe you the most expensive drug. So how are you going to have biosimilar adoption in Part B when the doctor gets paid more for prescribing you the most expensive drug? Now, that's possibly the stupidest system that's ever been invented for paying for prescription drugs, but welcome to the Medicare Modernization Act. That's what we do in Medicare Part B. Medicare Part D is a little bit better, D as in dog, because you do at least have private plans competing for your business as a senior on premiums, on price. The challenge in Part D is in dog is that we have these protected classes. There are 6 therapeutic categories in which you're basically required to prescribe, to pay for the drug, to cover the drug, regardless of its price or value. And one of those prescription categories or therapeutic categories, protected classes, is oncology. And that's the area where if you're a drug company or a biotech company, if I develop a drug that treats oncology and it's a monoclonal antibody, I can charge whatever I want because Part D plans have to pay for it. So it's effectively a kind of dumb coverage mandate. And as with coverage mandates in general, they're politically very hard to fix. The Obama administration tried and they backed out of it after a lot of pushback. The Trump administration tried, they backed out of it after a lot of pushback. So Part D plans haven't been able to do that. Whereas in the commercial setting, the employer-based setting or the individual market under the ACA, ACA is a little bit different. But in the commercial market, at least you have some flexibility, right? Obviously, the self-insured plans have total flexibility in how they structure their drug formularies. And for the fully insured plans, like the Texas-based plans, say you're obviously beholden to the state's coverage mandates, but those depending on the state can be better or worse than Medicare. So all that to say that Medicare in general is not a great model. The one thing that I will say that is a useful model is that because the Medicare Part D and Part C plans that have prescription drug coverage do compete on premium price to the senior, there is a powerful incentive to try to negotiate the best deal possible within the constraints that I've described.
Excellent, thank you. Can one of you guys look at the chat boxes in the Q&A, make sure we're not waiting on anybody? I don't want to leave any questions unanswered. I've got one more I really want to ask, but I'll defer if we have one in the Q&A box.
If you want, I can read you what's out there, and you can go from there. So there's a question to Lauren from Ken Janda that says, a big concern about pricing is the market failure for hospital-based physicians. Is there really any way out of this? There's a bunch of things he talks about: consumer choice, corporate practice medicine. There's a question from Vikas of PCCI about what explains the reduction in HHI, but still the increase in price in San Antonio. And then there was just a comment saying, good that we're talking about prescription drugs.
All right, well, let's not leave anyone because the first two got answered. Will you read, Lauren, that last one, the summary, and let Lauren take it?
Yeah, Lauren, a big concern about pricing is the market failure for hospital-based physicians. No opportunity for consumer choice, monopoly with hospital, prohibition on corporate practice of medicine, private equity funding, and insurance laws that require payments. Is there really any way out of this other than government price control in all markets? Question mark.
I mean, I think I fundamentally agree with you on this one, Ken. I don't think I think surprise billing and sort of the payment for hospital-based physician is one area where I think there is a pretty clear market failure simply in the fact that we as the government sort of allow discordant network status between hospital and a hospital-based physician who is supplying a service that is critically a part of the care that you are buying when you go to the hospital. You're not individually buying an anesthesia service, right? You're buying the surgery or whatever the care you're getting at the hospital is. Fundamentally, just there is a clear market failure there. And at the end of the day, yes, that is somewhere you just sort of have to say that is now illegal to do. You can then come in and sort of tell insurers you have to pay at least X, when there's an out-of-network service. But fundamentally, this is somewhere where I think government action is pretty clearly necessary. It's also not. I almost sort of brushed over it in my original talk as sort of tangential to the core issues here. But I should note, I think we have a recent paper out. If you just look at the kind of surprise billing services, your hospital-based physician care, and emergency physician care. Once you're looking at it, you're already up to about 10% of insurer claim spending. So this, it's not nothing, right? The 10% of everything that's getting spent is on just these services. So, the fact that we're probably paying, 15, 20% more than we should be without that market failure for those services, you're talking about a couple percentage points on premium that are really just derived from the fact that we allow surprise billing to exist. So yes is the short answer to your question.
That is a great answer. All right, if we were in Austin, which I really wish we were, because I love this conference, I would say at the end of the day, there's no reason to run long if we're between you and the bar. And it is 4:58. So I would say with all the questions asked, hopefully everybody has a home bar they can go to and congregate via FaceTime with each other so we can actually see each other again. But with that, let's wrap up. And I want to thank Niall, Lauren, and Avik for a really intelligent and fundamentally interesting conversation about why price is out of control in the healthcare system in the United States. Gentlemen, you were fantastic. Thank you for participating, and let's do this again next year.
Great.
Thanks, Paul.
Thanks for having us.
All right, thanks everyone. Laura, you can take us on down now.